What we're going to be going over today is a combination of what we've done previously. So previously I've done one on specifically prognosis, as how do we kind of look at the teeth and what are the things that we need to look at from an endo standpoint. I've done one on failures in particular, looking at what causes teeth to fail, what do we need to kind of preoperatively look at. We've talked about patient versus process-centered outcomes. So we've done some of this before. For the second years, this is when you were like 3 months into your residency. So I understand why you may not have remembered it. But what I think you were kind of asking for, Lindsay, and please correct me if I'm wrong, was how do we figure out when we want to do a root canal on a questionable tooth? When do we say, yeah, you're going to be great, your prognosis is fantastic, versus, no, you should just get this out and get an implant? Is that pretty much what you want the answered? Excellent. Okay, what we're going to be going over today is how I look at treatment planning, and this has changed a lot since I left residency, mostly because I've done a lot of work with my Spear Study Club and gone down there and seen how general dentists treatment plan, and that, if I'm going to say this in the presentation, but I'll say it twice, join a study club, learn a lot of it, because how many of you worked for more than like a year or two in private practice as a general dentist? Did any of you guys do that? Couple? Okay. So you're going to be a little bit ahead of your classmates because you already know what it's like to be a general dentist. You kind of know what it's like to run those schedules, what they have to do. And for people like me who came straight on through, we didn't really get that experience as much. So it's really good to work with your general dentist and kind of learn how they work as well. As far as how we have been viewed historically, well, it's kind of like this. You see, I would go to these meetings and I'd hear the general dentist talking to the orthodontist about how they got to meet and go over the case, and the oral surgeon's going to meet and go over the case as well. And pretty much we're just on the outside. It's like, wow, sure looks like they're having fun over there, having their meetings, talk about their case, because no one does that with endo. They never ask to go over cases with us. And historically, what we've really seen is more of a prescriptive dentistry, which is, hey, do the root canal. And they don't really tell you how you fit into the big picture. They don't tell you what the plan is. And they just say, do the root canal. And depending on how they handle it, sometimes it's understandable. Sometimes it's just do the root canal. I've been told this many times of, if I send you a patient, just do the root canal. It doesn't matter if it doesn't need one. And I don't love that. Personally, from an ethical standpoint, I don't think that's correct. So one of the things that you need to do is learn how to be part of that interdisciplinary team. And this is where something like a Seattle Study Club, a Spear Study Club, you can start your own, you can join in. Whenever you get to a new area, I know a couple of you had sent stuff about, wanting to work with local dentists in town. This is a great way to get in there. You're not going to be able to contribute much unless the topic is something like resorption, trauma. Actually, that's about it. Those are the only two things they don't really know about. Everybody kind of gets what a root canal is, but they may not necessarily know that we have a role in the treatment planning as well, and it can be a very useful role. So how do we get there? And like I said, learn as much as you can about every other aspect of dentistry. So I think I've told you this before. Most of the time when I go to CEs, it's not for endo. And the joke here is like, I'm usually teaching the endo. Well, this photo is Logan and me after I spoke to the Coolidge Club, which I was teaching endo. We went to a Seattle Study Club that was being hosted by a few of the specialists in his area. And I got to meet this super cool dude whose job was to open Four Seasons hotels. So he would fly out, train everybody, teach them how to do it. I learned so many things, and we didn't have any black and white. It wasn't even a presentation. This dude was impressive. He stood up for 4 hours and was on time. He had this presentation nailed in his head. It was very impressive. Even at the AAE, 99% of the time, unless it's one of my friends speaking, I don't go to endo-specific CEs. That's partially because they're usually sponsored and all they want you to do is just buy their toys. But I learn a lot from the people who are there who aren't endodontists, because that's where the defect in the knowledge is. That's where you can learn. So that would be the first piece of advice. Go spend as much time as you can learning about everything else besides endo. We'll talk in a little bit here, but I've gone to multiple Spear seminars, workshops, things like that, and I come away every time with something that not only changes how I help treatment plan and I help with treatment planning, but it also makes me a better endodontist. I change how I do things with knowing how the general dentist is going to prepare the crown, what it may be. And that's the other thing that I was in the kind of a weird phase, because when I was in dental school, we really just did PFMs. Lava crowns were just starting to come out, and it was just golden PFMs. And so the prep design, well, I had that one all memorized. And then I went away for 3 years for residency, didn't do anything crown-wise, and I come into this new office and they're doing everything CAD-CAM. Everything's this weird Emax lithium disilicate. They're talking about bonding versus cementing, and we didn't get any of that in dental school. And that was just 3 years of growth in the industry. Add on zirconia, add on all the new bonding agents. So you do have to stay up to date on this stuff. A lot of it with endo, you'll get by talking to your friends, by talking. I mean, you've already seen how much we're bouncing ideas back and forth off each other. So we don't necessarily need to go to as many endo CEs, but learning what general dentist's doing is so important for your professional career. What you want to get to is them saying, I am sending it to you to evaluate restorability. I know people who get annoyed by this question because they're like, I'm not doing the crown. I love this. I love that I am part of the team that will be helping this patient get back to health, and that the dentist trusts me enough to send it to them and figure out what needs to be, if the tooth is savable or not. So in a very non-Scott thing, I'm actually starting with the answers that you all want, which is, what are the bad prognostic factors for teeth? So if a tooth comes in and you're saying, I don't think it's worth saving, caries is going to be the first one, because the teeth are going to be under load. Doesn't matter what material we have, nothing is as good as dentin. And so if the decay has eaten away the tooth structure to the point that there's not a lot left, or it's in a bad part of the tooth, your prognosis isn't going to be great. So here's one that I saw a few weeks ago, and she really, really, really wanted to save it. The bite wing actually looked a little bit better, and I told her, I really don't think you should save this. She's like, I don't care. Open it up, see what you can do. And it was completely soft in the furcation. And really, that's the main one. If the decay goes into the furcation, it's not going to be worth saving. And there's a few reasons for that. The first is structural. So on multi-rooted teeth, a lot of those forces are going to go into the furcation just because of physics, and you're going to see fractures in that area. The second is cleansability or perio. When you get that spot that drops in, if we're looking straight down on the tooth and you have like the two roots like this, when it gets into this area here, very difficult to clean that area out. And from a restorative standpoint, unless you do really heavy scallops on the porcelain or zirconia or whatever you're using, it's very difficult to get a nice seal there. So it's very easy to get plaque accumulated in that area. If their decay level is this high, it's very easy to get decay under there as well. So that's my first one. If I see it go into the furcation, nope, we're done. Okay, next one, does the decay drop below the bone? And usually you don't see it drop below the bone. Usually it stops right at that bone level. But if we're talking crown lengthening, if we're talking, more advanced things, do you really want to do all that on a tooth that's already questionable? And some of that will come down to patient factors, which I'll go into for sure, because you didn't think you're going to get through one of my lectures without a little bit of psychology. But as it gets deeper and deeper, you have to think it's going to be harder for them to get a good margin on the crown, even with the new scanning stuff, even with lasers, even with tissue retraction, even with all those things. As it gets deeper and deeper, it gets harder to get a more accurate impression of the tooth, and your chance for recurrent decay is going to be a lot higher. The next one is how much tooth will be left. So in your mind, as you're looking down at the tooth, I want you to we're going to remove this amalgam, we're going to take this out, and then do a crown prep in your head. So you've all done crowns. We all had to graduate dental school. The difference between 1 and 1.5 isn't really that big for if you're just visualizing it. And think, okay, if all I have is the shell of enamel on the outside, and we prep all that away for a crown, how much tooth structure is going to be left? Some of this can be mitigated by their general dentist if there are some more like biomimetic dentists who will keep that enamel and hold it in place. But if you're sending it to a more traditional dentist who would just rip all the enamel off, tooth's probably not making it. It probably needs to be extracted at that point. We'll talk about the dentist factors in a little bit as well. And then the other one you want to think about is, what does the rest of the mouth look like? And we'll talk about finances and a few other things, but if you have just one single tooth that has nasty decay, needs a root canal, it's kind of questionable, but the rest of their mouth looks okay, maybe it's worth saving it. It's always better to save the tooth if possible. So an example of this would be if you have like a second molar where the wisdom tooth was coming in sideways, caused resorption, and now you have really deep decay, but the rest of their mouth looks super clean. I'm okay saving that tooth, even though it may have a more questionable prognosis, because their needs are really just that tooth and then regular hygiene. Versus if you look in the mouth and every tooth has decay, has broken restorations, if you're looking at the tooth and you're like, wow, that's a full mouth restoration, and they say I'm financially limited, are you really doing them a favor by doing the root canal on a tooth like this? Probably not. So we'll go into all this, but when you're treatment planning, the big thing here is you want to take a holistic approach and look at the entire patient and the entire mouth rather than just the tooth of is it savable or not. That one ended up getting extracted. The next one you have to consider is the good old perio. You can talk to your periodontist about it. But in a case like this, where it has combined endo-perio, hopefully you guys can see that. I don't know how good your screen is, but there is a defect that runs all the way like this. And in a case like this, where you have probably a failing root canal with defects here, with what looks like probably a cemental tear right there, that's a lot of strikes against the tooth, especially when all of her mouth looks like this and she had no idea she had any gum issues. She just thought her teeth were really long and those spaces between them were normal. Another one, if you're going to be doing a deeper restoration where you're putting the composite down, so think like a class 5 or maybe a ECIR lesion on the buccal, when you're repairing that, if you're going to have your margin subgingival, it's much better if it's in attached gingiva because the keratinized tissue doesn't care, versus unattached gingiva where you're going to have inflammation. It's going to be a mess as well. The periodontists are so happy I just talked about attached gingiva. And you can fix it with surgeries, with things like that. The other big one is the tissue phenotype. So you'll notice on all the cases where they show these beautiful aesthetic cases, it's all that really nice, thick, healthy phenotype. No one ever shows those cases. Like, have you ever seen an implant case on a thin biotype or thin phenotype? They change. Perio keeps changing the terminology. I don't know why. It drives me crazy. You can ask the residents, why do they keep changing it every 5 years? I don't know. Regardless, if it's that thinner phenotype, the chance of recession is much higher, the chance of issues is much higher. And this comes in when we're doing surgery as well. Is there mobility? And what you need to ask yourself, and if we have time at the end, I'll go through all the cases this week and we'll talk about how I treatment planned everything on some of them where they're questionable, some where they're not, and we'll kind of work through it because I've actually had a few good cases that I think would apply to this, including the one I just did. If there is mobility, you need to ask yourself, is it because there's a large infection and there's no bone, but it will grow back? Or is it because there's no bone from perio and it's never coming back? And then the final one is that god-awful staging grade system that they switched to. The reason they did that is because especially that grade, it shows the speed at which they are losing bone if they're having their periodontitis. So one of the ways you can figure this out is if you ask them, are you seeing a gum specialist for this? Sure, I've been seeing Dr. Antoine for the last 20 years. We're nice and stable. Great. Versus, what are you talking about? I don't have any issues with my gums. If they're nice and stable, yeah, you can do more questionable work because they've been stable for quite some time. And you can always call the periodontist and ask, hey, is this good? And if they say, who's that patient? I don't remember them because they haven't been here in 20 years. That's a red flag as well. Any questions so far? Those are the two main ones that we see where prognosis-wise from structural issues. Any questions on that? Cool. Fractures and cracks. I started writing this out and I realized I was just doing an entire lecture on cracks, which I will definitely put together for you all. But this is actually from 2003, this article that Clark and Paquette and Sheets wrote on if we have early enamel cracks and using the microscope and looking at prognosis. But really the cracks that you're worried about are the ones where the tooth is going to split in half and it's not going to be savable anymore. So this is from the endo standpoint. And the big ones that worry me are any cracks that are large, well, I said that weird, that are large enough to house debris. If there's junk inside there, not only does it mean that it's a very wide fracture or crack, it also means that bacteria are probably inside there. There's probably caries with it as well because they're getting crap stuck down inside there. That's not a good sign. I tend to not experiment and try to save those because it usually goes pretty poorly. If you have, and I'm thinking primarily of 18 and 31, if you have a fracture on the distal marginal ridge, smack dab in the middle with like a big plunging cusp on 2 or 15, and you look at the cone beam and there's a vertical defect that goes with it, and a narrow vertical one, not a big one. So not a full vertical root fracture where we look at it and split all the way down, but the start of one. Generally, those don't do well either. And there's the asterisk there because there are a few cases where you can get away with saving those teeth. We'll go into that when we do the actual crack lecture. And then the final one is, okay, you access the tooth, you see there's cracks underneath there, you start going down. Once they get near the pulpal floor, it's usually not good. Usually that's one where if they really want to save it, I'll put it on calcium hydroxide and see how they feel after a month. And if they're still having pain or symptoms have returned, that's usually a sign that the tooth's not going to be worth saving and it should be extracted. And I would say maybe of all the, and I don't do this very often, maybe 25% of them end up getting saved and probably 75% get extracted, just because it's way more questionable when you do that. So these are the crack things that you need to worry about. We'll do a full talk on that later, but like I said, I got excited and started writing a bunch of slides and realized I was writing into a whole nother lecture that you guys didn't want to have. Another big one is feral. When I started working at that office, I was very fortunate in that I had pretty much 100% recall because I was in a big general dentist practice, so they would all come back for their hygiene, so I could get x-rays all the time. And what I know, one of the big things I noticed as far as failures were structural. I had a couple biological ones where I missed like MB3s or mid-mesials or stuff like that. But any of the teeth that I did where they didn't have a ton of feral remaining, most of those are now implants. And so learn from my lesson. What the studies have shown and what I feel as well, if there's 0 millimeters, if it's a complete snap off, don't do it. It's not worth saving. Most of the time, these teeth are going to be way better off as implants. If you have a millimeter above the gingiva, okay, maybe in the right patient, maybe in the right tooth. Are there other factors or the ways that we can save it? And really 2 millimeters supragingivally is the accepted minimum. That's what you want to have as far as your feral remaining. Now, which walls also matter. And what they've shown is buccal lingual tends to be more predictable than mesial distal. And so in this case, this is my deep marginal elevation case. I'm not sure you guys saw that video. He had good-ish feral buccal lingually, but it was a crown that we cut off and there was recurrent decay right here down to the bone. So this is where you can do that deep marginal elevation, build it back up, and then now the margin's going to be right here. And it's okay because biologic width doesn't really care about composite. Don't tell the periodontist I said that. Also, it's not really important in the posterior, but they care a lot more about crowns and they care a lot more about the anterior. So this is a way that you can take a questionable tooth and kind of keep it around for a little bit longer. And then as far as which teeth, you want to think about what type of force the tooth's going to have. Feral is primarily what they talk about as crown dislodgement. That's kind of how that all came down. And so if you don't have anything to grab onto, it's easier for the crown to pop off than if it's stuck on the tooth and held in place. So the teeth that have lateral forces, it's a little more important to have more feral. However, one of my rules of thumb is if I think a molar is broken down enough that I would need a post to retain the core, it's gone. That should be an implant instead. Implants in the posterior are very predictable most of the time. There's lots of, I feel like I should be saying allegedly there. There's a lot of people who are fine doing molars in the posterior, whereas an anterior one, or doing implants in the posterior, whereas an anterior one is a lot more difficult and has a lot more things. So we'll talk about that too. I tend to try to save anterior teeth because of the aesthetic reasons too. Another one here, what did they come in with? This will also be, I'll probably talk about this when we go over retreats, about when you actually want to do a retreat. And you want to think how much tooth structure is left. What were the shapes that they used? Are they blowing everything out or did they destroy it? And sometimes it's hard to tell how much tooth is left until you cut the crown off or access the tooth. The other question is, why is this one failing? And is it a strategic tooth? So this is one of my actual failures that I saw yesterday. I retreated the tooth a couple years ago. It had a missed MB2. She didn't need anything else. She was down to save it. Crown still looks good, even though it looks like there's a gap there. There's not, I promise. And we ended up retreating it, found MB2, and then she came in yesterday after biting down on a nut and split the tooth in half. Has to be extracted there. Speaking of strategic teeth, I assign different values to this. And so what you want to kind of think of here is every little thing that you're doing is a test, and you're adding or subtracting to, do I want to save this tooth? And if it's a strategic tooth, you're going to be adding to it. If it's a non-strategic tooth, you might be leaning towards extracted implant. What are the teeth that are strategic? My number one is a canine. They are terrible implant sites. There's nothing else that we have. They're terrible for bridges. Don't even talk to me about putting a partial on there. They're such an important tooth, and they're usually big enough you can get away with more compromised treatment on them in general. Want to save every canine, I will do tons of crazy things to try to save canines. First molars are another big one. It's the largest tooth surface area wise in the mouth, and so it's a very important structural tooth for those reasons. Anterior teeth, if they are restorable and it's in the right occlusion, that's why there's an asterisk there, it's much better to keep an anterior tooth than an implant. We have time, right? Oh yeah, we got time. A few years ago, my Spear Study Club wanted to go down and take the implant course. And I was like, great, it's just going to be about how endo sucks and how you should never do a root canal. You should just do an implant from the very beginning. And I was so surprised by how often they said, if you still have a tooth there, do everything you can to keep it, even if it's questionable, because they were showing cases where they had like a nub of a tooth that really wasn't going to be worth anything, but there was no bone from, say, like perio. And they'd have the endodontist do a root canal on it. They'd put a little attachment on it and slowly start pull it down, shaving it off as they did it. And as they pulled it down, they could build bone for an eventual implant. I've actually done a few of these where we've had cases that are, not really worth saving, but we do need to create bone for an implant. And there's no better bone than that you create by putting a tooth, or that a tooth creates. You can't graft that area per se. So that was kind of nice. And then the other thing we're seeing more and more is that it's very difficult to predict. And maybe you guys actually ask the perio residents. I'm kind of curious what they're learning right now. For what age they consider the minimum to place implants on both males and females. Because for a while there it was 21 for males, 18 for females. Now it's kind of creeping up, more like 25 for males, 21 for females. And I'm seeing cases in the literature out there of 70-year-olds that 10 years later at 80 have had vertical growth. And now it looks off like it was done when they were 18. I think the general consensus right now, unless there's some reason you have to take the tooth out, for an anterior tooth, you really want to save it no matter what. If the tooth is an existing abutment to a solid bridge, definitely want to save it. If the tooth is an existing abutment to a partial, you want to save it. Now, if it is a questionable tooth and you know they're going to be going into a partial, I wouldn't save it, because it's expensive to get that framework built. That's one of the biggest costs of partial dentures, is the metal framework. And it's very important that they grab it correctly. So if you have a tooth that you think after a year or two of getting moved on, if it's a distal extension, if that tooth's going to be extracted, may as well speed it up, extract it now. Most of the time, these are premolars that they're grabbing onto as well. And premolars make a great implant site, and implants can make partials a billion times better. What you end up doing is you place the implant, and instead of putting a tooth on top of it, you can actually put a locator attachment. That'll snap the partial into place. And the cool thing is you can usually get rid of clasps. So that way patients really love this because they don't want to have the metal in their mouth. And so by having the locator in there, it snaps into place, gives them more stability, and then they can also look better too. And then if for some reason they can't have an implant, that's when we'll do crazy. I've buried teeth before on cancer radiation patients, bisphosphonate patients, things like that, where you can't have an implant for whatever biological reason. You want to save those teeth. All right, non-strategic teeth. Second molars. I tell people to get second molars extracted all the time because the way the bite comes together, they're usually, especially maxillary, they're usually not going to be in the bite. They're not really that useful. Most of our chewing that is done with the first two premolars and the big first molar. Very, very little is done on a second molar. So that's when you can feel comfortable. Toss it. Premolars in general are stupid teeth. They were designed, whoever designed us designed those teeth poorly because they're shaped like little molars, but the roots are so small, they're not designed to take that much force, and it's very common to fracture those bad boys. So if you have a questionable premolar, more likely to extract. And then the other one, kind of like I talked about with the RPD, if it's an ideal implant site and the tooth itself is questionable for whatever reason, do the implant. There are times when people say, I really want to save the tooth, and sure, we'll go for it. But implants are a very useful tool, and it's good that you guys learn about kind of what you can and cannot do with implants for sure. Now, you guys did ask about like large lesions as far as their prognosis. Do you guys did the second years remember this lecture? It was in December of 23. Cool. It's been so worth doing these things. I'm so happy that you guys have, paid attention. No, it's okay. And we can recap some of it real fast, but I don't consider a large infection to be a contraindication to treatment, because this was the conclusions from that. If you're concerned about it, you start off by doing calcium hydroxide. If that doesn't work, you can switch to something like a Vitapex or doing a decompression. Or if that doesn't work, you can do an Apico. If that doesn't work, you can always extract the tooth. I don't ever go in saying, oh, the lesion, the finding is too big, it needs to come out. And the other thing you can do, and this is transitioning to the psychology of it, I'll often, on cases like that or questionable crack cases, I'll use calcium hydroxide as like a test run. And the line I give is, let's give the tooth a chance to prove to you and me that it's going to be okay. And what that does is it puts you on the side of the table with the patient, and their tooth is on the other side. You two are just looking at it like, you prove that you're okay. Otherwise, it's a really cool way to get the patient to understand, like, okay, I'm on this guy's side. Yeah, that's stupid too. Oh, it's attached to me? Don't worry about that. But it's a really good way to help the patient understand that what you're trying to do is save the tooth, but it may not be savable, because that language is very difficult to get. So that line works really well. Let's give the tooth a chance to prove to you and me it's going to be okay. Moving on to the patient factors. And I think this is probably one of the biggest ones. My advice for you, don't do a questionable root canal on a questionable patient. It's going to go badly. You're going to have something go wrong. They're going to be upset. You can work on more difficult patients for sure. We all will. But you probably don't want to roll the dice on those, because the odds are definitely stacked against you. And on that same factor, don't really want to do these questionable root canals on a doctor who may not be operating at the highest level. There's one in St. Louis who I believe is still there, who may or may not have sent in a bunch of root tips for us to do root canals on once. I think you guys have experienced some people like that. But there's a wide spectrum of dentists. I have done, I think, a really nice job of filtering, so I get really awesome I love my general dentists. They're absolutely wonderful. And if you want to kind of talk about that, I'm happy to share some of the tips that I have for getting in with the best general dentist in town, because it's way more fun to see your work get a perfect, beautiful crown as part of a big treatment plan versus it get a crown that has a 2 millimeter open margin and you know it's going to fail. That sucks. That does not feel good. Okay, so what are the patient factors? The first 6 lectures I gave you of clenching, grinding, myofunctional plane, hyperinflammatory, if they are a problem for those reasons, it may not be the best patient to do a questionable root canal on. One of the lines that I really like to use, and I'll be giving you guys a bunch of the phrasing and language, but how did you lose your other teeth? So if you look, I had one recently that had implants on 3, 14, and 30, and 19 had a crack. So how'd you lose your, I see you have implants on those other teeth. How did you lose those? Oh, I broke them all in half. Okay, do we really want to go down that road again with a questionable tooth on number 19? Or has the patient already shown you, I'm going to break things? You just need to go to metal at that point. Is there other specialty work that needs to be done? And so I've already talked about the perio one, where the patient wasn't even aware they needed perio work, but ortho is a really, really, really big one. Is their bite collapse? Do they have severe tipping? Are they even willing to do ortho? And I've had multiple times where I've told them, we can save your tooth, but I'm not going to do it unless you go get braces, because it's just going to fail. So learning, you actually are in a good spot with having both peri and ortho in your program as well. Learning what an orthodontist can do, learning how they do it, that was one of the biggest eye-openers for me. So go talk to the ortho residents and just say, what do you guys do with adult patients with crowding, with tipping, with, overclosed? How do you open up video? What do you guys do in these areas? And it'll get you an idea of, hey, they can actually do that, or they can't actually do that. So I'm friends with a great orthodontist in town, and we actually had one where it was a snap off on number 20, and the patient had been missing 21 for quite some time, and it was a big old defect. There wasn't enough space for the implant because it was getting close to the mental. So what we ended up doing is I put a big old fatty metal post in there and then just did a cylinder of composite. They banded it and over time slowly moved it into the space of 21. That tooth was then extracted and she got 2 implants placed in there. So there are cool things that you can do. It's important that orthodontists know about this as well, that you can use strategic roots, because at that point it really wasn't a tooth anymore, to build bone using ortho so that you can get space for an implant. One of the lines you'll hear me talk about a few times is how much can you contribute to your oral health over your insurance benefits? Because you're going to get patients who come in and say, I'm only going to do what my insurance pays for, versus, hey, I understand that I need a lot of work and I'm ready to invest in myself. Which leads me to insurance. How many of you guys have a good understanding of how dental insurance works? That's what I thought. Okay. This also needs to be its own lecture. I've actually given this lecture at TDO with my office manager. But a few things you guys need to know. In general, you're going to have different coverage tiers for most insurance plans. And this is just an average, kind of like we talked about with private equity. It's just an average of it. Preventative is covered at 100%. And so that's things like cleanings, exams, but it also is PAs, bite wings, sometimes the pulp testing if you're charging that one. Then you have your basic. That's going to be covered at anywhere from 50 to 80% depending on the plan. Most of them cover around 80%. That's things sometimes like the consult because it's a specialist, but in general, that's going to be where the root canal is most of the time. And then you have something called major, and that coverage is only at like 40 to 50%. And sometimes root canals get thrown in there as well. Crowns usually are in this category. So crowns are usually only covered at 50%. The other thing you need to know is that there are different maximums, there are different deductibles and waiting periods. So the maximum is the maximum amount that the insurance plan will pay out in a year. So that doesn't mean if you charge $2,000 for a root canal, they're only going to pay that. They're probably only going to pay like $1,000 because the patient pays the other half, and then it only takes away $1,000 from their maximum. Deductibles are the amount that a patient has to pay before the insurance kicks in. So if we see this a lot in January where there's usually a $50 deductible, so they have to pay $50 more than they would at the next appointment just because they haven't got to that point yet. And then there are these things called waiting periods. And that means with dental insurance, what they're trying to do is prevent people from not having insurance and then realizing, oh, I need thousands of dollars of work. I'm going to go get dental insurance just to go spend the money and then drop it later. So you can see from a business standpoint why they wouldn't want to do that. And each plan's different. These are mostly for plans that they buy off of like public markets. If you get the insurance plan through your business, generally there's not going to be one, but you have to, there's a lot of nuances to insurances. Which means that if the root canal is labeled under major and they went to get the insurance because they need the root canal, you have to tell them you don't actually have any coverage for this for a year. That's a tough conversation. And so it's really important to learn these things so that your staff can communicate it effectively, because very, 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 very rarely has anyone ever complained about my actual work. It's always financial. It's always insurance. And we have tried to do as much things as possible to help people understand it. And it's still very difficult. So the question then, and you guys have probably heard some smug older dentist talk about how the maximum benefit hasn't increased since 1970 and a crown was only $100 back then. Have you guys all heard that before? And they're asking, why aren't the maximums increasing anymore? This is from the organization of dental insurers. Did you know they had a plan? They have an actual group. They lobby, they do their stuff. Only about 4% of patients even reach their maximum throughout the year. And when we say that, people lose their minds because they're like, well, my patients all meet it. Well, you're all endodontists and you're all going to charge that much. But for most people, they're not going to meet that much. They're not going to meet the maximum, which means there hasn't been that incentive for insurers to increase the maximum. And the reason why they don't reach their maximums is generally because of that copay. So if you're charging $1,600 for a root canal and it's in the major at 50%, that means the patient's portion is going to be $800. Do you guys know? I don't know if you guys know this. The Fed Reserve asks this survey question every year, which is how many Americans cannot afford a $400 emergency? And so this is from 2023. This is the most recent data. But about 37% of Americans cannot afford a $400 expense, and about 60% cannot afford a $1,000 expense. And so it's actually that copay. It's the part that the patient owes. It's not necessarily the insurance. That's the issue. If the insurance covered more, it wouldn't be a problem. So the question you're going to have to ask yourself, kind of like my example of the, molar coming in sideways causing resorption, you need a root canal on number 31, versus they need fillings on every single tooth and there's a questionable tooth, you need to do a root canal. Does this patient need care that's probably going to go outside their insurance limits? And if they do, is this root canal an important tooth to save because of it? So that's how I kind of approach the financial side, because what we do is expensive because it's very hard and there's not many people who do it. So we do deserve to get paid well for it, but you have to think about the financial implications for your patients as well. Okay, a few more things. Oh, we still got time. We're good. Mindset. So this is a really big thing of what is the patient's mindset about dentistry, about dental care, about their role in the dental care. And so this is all about phrasing. I love Archer. Way that you can ask this question, you want to make sure you don't ever shame them or have judgment. And so you can say, I see you have quite a few teeth with cavities. Any idea how they got there? And the responses can be all over the place. We can have, my mom had bad teeth. It's just genetic. She had weak enamel. The baby sucked all the enamel out. It sucked the calcium right out of my teeth. That's what happened. It was the baby's fault. She sucked the calcium out. I didn't have insurance. And that could be one of two things. That can be they don't understand that you don't necessarily need to have insurance to go see a dentist. And it can also be, I'm very financially motivated. I'm only going to do what insurance pays for. Versus, I drink a pack of Mountain Dew a day. Why do you have to say it like a cigarettes? Why do they always? Have you guys noticed that? It's always Mountain Dew. 2-pack a day Mountain Dew habit. Don't. That's not good. Versus, I was depressed. I didn't take care of myself. I got help. I want to get my teeth fixed. That last patient's the one who they're motivated. That's the mindset you want. You don't want to have the, oh, it's somebody else's fault. Oh, I didn't, financial. Oh, I'm going to make bad decisions with the root canal you're about to do. I know it was on me. I'm ready to get this taken care of. This is the patient you want to experiment on. And by experiment, I'm saying do a questionable root canal. All right, next one, reliability. How long has it been since you've seen a dentist for cleaning? So this is a question I'll ask patients all the time. You don't want to ask them how long has it been since they've seen a dentist, because they'll probably come in and say, last week when I went to see Dr. Smith and she sent me to you because I had this root canal. That doesn't answer the question, which is this someone who reliably goes, takes care of their hygiene, and is going to take care of the root canal that you're putting in their mouth? If they've been away for a while, a really nice way, and shout out to my friend Michelle for this language, what kept you away? There's no judgment in that. There's no shame, and it makes it so they feel okay answering. And once again, different responses have a different patient. I'm terrified of the dentist. Great. I know on this one, we can talk about sedation. We can get them comfortable. We can make them feel, able to get their treatment. Once again, I didn't have insurance. There's two ways to that. Versus, I only go when it hurts. I've definitely seen this one. Super questionable tooth. I'm like, no, we're not saving it. It's going to be a waste of your time and money and my time. I'm not doing that. Another one you'll hear is, I focused on my kids as they were growing up. They're now in college. I want to get my own teeth fixed up. That's the patient you want to work on. That's the one who's cool. You understand where you're going. You understand you need to get the work done. Great. Another one, what are their goals and do they have a current treatment plan? So a way you can ask this, is this the first time you met Dr. Smith? Or has she gone over your whole mouth and worked on a plan with you? That's going to answer, did they come in just for a limited, and because they're in pain, Or did they get the comprehensive exam, have a plan together, and you're going to be part of that comprehensive plan? Because oftentimes we are the first stop. Us in oral surgery are the first stop of they're in pain, new patient came in, they come in through the emergency side, they send them over, they haven't even looked at the rest of the mouth. They just know, oh, number 15 hurts. Cool. What's the rest of the mouth look like? And if they are financially motivated, if you take up all of their insurance benefits by doing that number 15 and all the incipient caries get to be gross caries and they need root canals on the rest of their teeth, did you do them a favor? Probably not. And so in those cases, that's where you might sacrifice a second molar or a non-strategic tooth to have them get the preventive care that's going to actually help them in the long term. Another one, what are your goals for treatment? I don't want to lose any more teeth. Okay, that's someone who's been to the dentist, that is willing to roll the dice, experiment on a questionable tooth. I want to eat, function. That's a great one. That one is a good patient to have. You got to see how aggressive they are when they eat from occlusal side. Hollywood smile. Well, is it somebody who has teeth that can actually turn into a Hollywood smile, or would they be better off getting a denture because that's a full mouth reconstruction in one? Fix the broken ones. These are all things you might hear. The best motivator by far is my wedding's in 3 months. I heard that one this week. That's why I put it in there. If their wedding is in 3 months, they're showing up. They're getting there. They're not canceling their appointment because they need to get this done ASAP. And then once again, this is a really nice line. How much are you willing to contribute to your oral health over your insurance benefits? And I will often give patients a rough estimate. So if they come in and need fillings on a bunch of teeth, I'll usually say something along the lines of, your maximum benefits is about $2,000. Looking in your mouth, you probably need about $6,000 to $7,000 worth of work. I'm going to take up, $1,500 of that with this root canal. And would you rather invest in saving the other teeth than this one? Okay. The other big one is, what is their mindset for failures, or said another way, what is their risk tolerance? So we talked about this in one of my lectures previously that you guys all forgot because it's been a year and a half, but there's a big difference in 5-year outcomes versus 10-year outcomes. And when I first started off, I just wanted to get to that 5-year mark. And then after being out for a couple of years, I realized I wanted to push it out to 10 because I want my work to last a lot longer than that. So I will always tell patients if I think it's not going to make it 10 years. And I usually say something like, I want all my work to last as long as possible. And so my number is I want it to last at least 10 years. I don't think your tooth is going to make it that long, but if it does, I'll be very happy. I think it has a good chance of lasting 5 years. So if you spend all this time and money in investing in this tooth and it fails in 5 years and you have to have it extracted, would you be upset? That's a nice way of figuring out their risk tolerance, because some people will say, no, I want to save my teeth. Let's do it. Lean them back, get them numb, go for it. If they're like, I don't know. Maybe, I'm not sure, then it might be wise to see them back for a second visit after they've had a chance to talk to their dentist or talk to family members or whatever it may be. Then we'll finally finish up with a referring dentist. Have you worked with them before? Have you seen their cases? Do they do comprehensive treatment planning? Do they do more of a prescriptive, just do the root canal, versus do they like working with people? Are your other specialist friends saying, oh, I love working with Dr. So-and-so. They're great. We work on these huge cases together. They do a great job. And then the final one is the patient-centered treatment planning. So are they the type to say, don't you dare do the buildup. You're stealing money from me on a case that would make their life a lot easier. And I'll definitely have a whole thing on restorative. Versus, no, save that tooth. We're going to get it rock solid. I work on a bunch of kids, as you know, and ideally, you want to wait a while to put the crown on top of there because you're going to have growth. And most kids aren't big enough that you're actually worried about fracturing the teeth. If they're going through ortho, if they're going through, whatever it may be. And certain dentists will get upset with me because I told them, let's say it's just occlusal caries. You got a good ring of enamel around it. I seal it up. It's rock solid. They need ortho. They need other work done. They said they're concerned financially. And I've gotten calls in the past from general dentists upset because they wanted to put that crown on that 11-year-old because they wanted $1,000 in production. Much better to take care of the patient. You'll get the crown eventually. Because of inflation, the price is probably going to go up. And that's the type of dentist you need to be careful with doing something questionable on, because they may not be as willing to experiment and the work may not be as forward thinking. Was that said diplomatically enough? So to finish, what I'm encouraging you all to do is to take a holistic approach to treatment planning. It's not just what's going on with the tooth. If you see a crack that goes this way, it's not worth saving. It's not, oh, if there's caries this deep, take it out. Really, yes, there are some obvious, there's black and white for some of those, but there's a lot of gray. And it's more important to focus on what's the patient that this tooth is going to be attached to. If they have financial considerations, how are you a part of it? And then what's the referring dentist that you're working with and how will that all go? With that, go ahead and stop the share.
So what's the process like for your patients when they come in? Like, when are they having that financial conversation and who are they having it with?
Good question. So we try to do all of this over the phone if possible. So the first phone call, we're going to get the information, and that's all the demographic, name, address, social, age. If they have insurance, what's the address associated with that? Who's the blah, blah, blah. And then at that point, we should have gotten the referral from the dentist, or we should at least have an idea what needs to go on. So we'll put the codes in, we'll go through and we verify their insurance. So it's pretty easy to do online. And most of ours now, thankfully, we don't have to call anymore because that takes forever. So it takes my staff about 2 to 3 minutes to verify an insurance. All of them know how to do it. So that could be, I can almost guarantee that's one of the things they were doing while I was lecturing right now is verifying insurances, because what that allows us to do is the insurance is going to say, we cover this at this percent, this at this percent. So you put it all in and spit it out. Then we have a second phone call with the patient. And at that point, we say, we had a chance to review it. Do you have a second to go over it? And here's your coverage. We always start off with the total amount. We start off with the insurance contracted amount. So that number goes down, so it looks good. And then we say, here's what the insurance pays and here's what your portion is. And that's the first financial hoop they have to jump through. Do they have, it's called a filter. It's a big thing in Spears. You want to filter your patients as they come in. So do they have the means to at least get this done? Do they at least have the ability to pay to come into the door? So that's the first step. Then once they're there and I'm looking at everything, that's when I'll start to ask those questions like, have you seen your dentist? What did they do? Like, have you had the comp exam? Do you have a plan? And if I think that they're questionable, that's when I'll start probing and saying, okay, I'm taking a rough look here. I can't see everything, but it looks like you need a lot of treatment. How much are you willing to invest? And that's when you have that conversation. So some of it's done by the staff for the stuff that can be standardized. Like, we always charge a consult. We always charge a PA. We cone beam, blah, 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 blah. And then customizing it, I think, is better to have it be done by the dentist. Good question. What other questions you guys have?
If your work does fail over a short time frame, you've had a conversation with the patient. You ever offered a refund?
It depends, as usual. So if the work failed because of something I did, 100%, for sure. If I missed an MB2 or something, of course, I'm redoing it. Thankfully, I don't have those much anymore, but at the beginning, if something went wrong, like if I perfed a tooth and it failed, yeah, for sure. If they did something stupid, no. So if they're like, yeah, I was opening a beer bottle with it and it broke the tooth. Okay, well, that's happened. If they never go back to get the crown, and it was an attempt and it's caries and now it's extracted, no. And then the other one is, okay, on a questionable tooth. And by doing those questions, or asking those questions and looking through everything, I've gotten a lot better at figuring out when they're going to be questionable. And if I've had the conversation with them that, hey, it's kind of a coin toss, and make sure you write this down, then usually no. If they were down to experiment, they have to have some skin in the game as well. And I have friends who will do the exact opposite and just give money back all the time. It's based on your comfort level, pretty much. But I remember one where she had this huge post. It was number 12, and it had snapped off. It was really, really questionable. And I told her, I was like, I don't think this is worth saving. A line that I'll often use on those patients is the warranty ends when you walk out the door. That's a good one of, hey, you're not getting any money back. Sure enough, she came back like 6 months later, the tooth had cracked. And no, she did not get anything back from that one. Yeah. Good question. Lindsay, was this what you wanted, hopefully?
Yeah, it was really helpful, and that was kind of my main question what Jacob said, because I feel like, I mean, especially here, I think we are still getting referrals from that one that you had previously mentioned, and I feel like I noticed we have this conversation being like, hey, pretty questionable, you want to do it? And they're like, let's go, and then I finish the case, and I'm like, okay, still questionable, and they're like, what?
Yeah.
Like,
and
so,
a lot of this, I mean, right now, you guys aren't the ones having to write refund checks. You're not the ones having to necessarily deal with the upset patients. You're in residency, your goal is to do the root canals. And so if you have, I mean, don't like malpractice, but if you have a questionable case, do it. You'll learn from it. It'll be good. The more reps you get in, the better right now. Once you're in charge and have to be the one writing the checks and be the one fielding those nasty phone calls, that's where this lecture hopefully will help you figure out which ones you can kind of experiment on and which ones you should tell just to get extracted. Any questions from the left side of the table? No? You guys are all just quiet? That's okay. Cool. Alrighty.